Dear Chairman, Professor Hamm, ladies and gentlemen, first a warm welcome to everybody here in the audience. And I believe this is a very hot topic today because we have to speak on the impact of smart fusion technology on the diagnostic outcome. And first I will briefly outline the possible indication for the use of this new method. We move on to prostate cancer detection in combination with this new technology. We have to talk on Bosniak renal cyst classification system and focal liver lesions, especially in the field of monitoring of therapy, as well as of staging CT and ultrasound. What is the impact on this technology? Please first have a look on this. If you deal with prostate, you have to know the normal size of a prostate in a young man is in a range of a chestnut. Becoming older and older, you see what happens. You see tangerine, orange and grapefruit, maybe a benign prostate hyperplasia, maybe a tangerine cancer. So that's the problem. And the most technology to see the cancer for the detection and for puncture is a so-called transrectal ultrasound biopsy. And you see here the tangerine situation, a biplane situation, where we see exactly the situation from the transrectal point of view. This is a new technology which is named fly-through, and look at this area. This is the tangerine cancer. Looks quite similar to this area. This is a fly-through reconstruction, and of course MRI imaging is also not so bad. For the introduction of this technique, and especially for prostate cancer detection, we use multi-parametric MRI techniques. We use T1 weighted sequences as well as T2 weighted sequences, and of course also diffusion weighted imaging. The most impact, especially for the fusion technology, is to see the cancer in the T2 weighted image and in the diffusion weighted image with a perfusion restriction. Of course, you can use three-dimensional ultrasound techniques, and look at this, how beautiful it looks like in the ultrasound reconstruction, this part of the tangerine. And of course, MRI is also very nice to reconstruct the volumetric feeling of this tangerine. How it looks like in the procedure room. This is exactly the situation in the room. This is the needle tip, tipping the tangerine cancer, and then we push the fire button and we have a biopsy. And this is the same situation on your left, MRI imaging, T2 weighted imaging. On your right, ultrasound, the needle is coming directly in the central portion and we see a slight bleeding of the tangerine. It works very well and it's a very safe procedure to analyze this patient very careful. What happens on this technology in the patient situation? We have to talk on prostate cancer detection and fusion biopsy. You see first the normal and systematic biopsy, often in a so-called end-fire situation. This is an end-fire probe where you see the needle tip in a guideline, and you see on your right the typical schema to have 10 or 12 samples in the patient situation, and this is an example here of an histological specimen of this technology. What is the problem of this technology? We know that important cancers are missed by this technology. Clinically insignificant cancers are identified by chance, like in that image. And we have an undergrading of the Gleason score in a range of 36 up to 46%. That's a problem of this technology. And if you see the rectal probe is located in this position and we puncture the patient here and here and here, we miss this ventral cancer here, a big mass of 3 centimeters. And this is an example where we have 5 times before a negative biopsy based on a transrectal ultrasound way. And you see how easy is this to detect the cancer based on MRI imaging. This is the same situation in ultrasound. This is the 3D volume, the sagittal or axial scan plane, and the coronal view of the prostate cancer, and a nice reconstruction in the fly-through mode where we see the localization of the cancer in this atypical localization. This is exactly the procedure before the biopsy starts. This is the T2 weighted imaging, and the diffusion restriction is very well visible. Of course, for study reason, we use also a dynamic MRI scanning, but for the fusion procedure, the T2 weighted image is very important. Here is our target. That's the tumor. That's the border definition, the outer contour of the prostate with some marker points. We used in an additional way also the so-called tissue Doppler imaging to see the vibration artifacts directly in the tumor. This is the perfusion of the prostate cancer. We see an early and fast enhancement in the cancer. And of course, this is quite good comparable with the dynamic MRI scan. And this is the procedure in the operative room. You see here, this is not only an image fusion, this is also a brain fusion, because this is an urologist, that's me. And you see, we play like a piano with a four-hand technology. And on your right, this is exactly the situation in the ultrasound real-time mode. On your left, MRI scanning. On your right, ultrasound scanning. Here's the needle tip, and we have a good access way to the tumor. And I'd like to show you the final result. You see, this was the cancer, a Gleason score 4+3, an intermediate risk cancer. And we see once again the needle tip very nicely in the tumor area located. And that's the normal gland in correlation to the prostate cancer in that case. Another important information, because we can use all different things in the field of ultrasound, this is an elastography result where we see there could be a disruption of the prostate capsula, and of course this is also a very important information for the surgeon. Here you see the problem. We have to detect especially the high-risk cancers, and I believe that's possible with the new technology in terms of free Tesla MRI scanning, because the prognosis is definitely better than in correlation to the low-risk cancer population. What about small cancers? Look at this example. Once again, tissue Doppler imaging. This is a tumor which is 4 millimeters in size, and the question is this possible to have a puncture analysis of this small area? And I can say, yes, it's possible. Look at this, highly vascularized, based on the power Doppler evaluation after contrast application, tissue Doppler imaging, and then we see exactly here the simultaneous look on the tumor. The needle tip is coming. We push the fire button, and I show you the final result. That's the needle tip exactly in the small hypoechoic mass in a range of 4 millimeters. Sometimes we have cases like that. This is once again a T2-weighted image, and if I ask the audience where's the tumor, I think it's very hard in that case. We have to use diffusion-weighted imaging, and if you look at this, you see the restriction very clear here, maybe there. And this corresponds very well with the three-dimensional evaluation of this tumor. This was a tumor area, here was a small tumor area, and also on the right side, which corresponds very well with the diffusion-weighted imaging. These are our results from our first study, and I must say this is an ongoing study with 2 high-end machines. First results with the Hitachi platform as well as the Toshiba platform, and we studied so far 50 patients, and we histological confirmed cancers in the study group of the fusion biopsy in 20 or 50 cases. This is a detection rate of 40%, and there was a significantly difference between this group and the transrectal ultrasound biopsy group, where we have only 22% detection rate. What about Bosniak renal cyst classification? And of course, we have to know first, we have a very nice B-mode quality. The kidney looks like an anatomical booklet, in my opinion. We see the vascular architecture based on advanced dynamic flow Doppler techniques. And this is contrast application, which is now available for a linear transducer for a better delineation in the kidney. And you see exactly from this interlobar point of view, it takes 9 seconds to have contrast in the medullary phase. And of course, ultrasound is a real-time modality, so I'd like to show you this once again in real time. Look at this, kidney perfusion, very fast. It takes some time, but this is normal to have contrast in the medullary phase, exactly 9 seconds here in that example, and this is possible. We use this technology especially for the Bosniak renal cyst classification. This is an example of a simple cyst, typical hemorrhagic cyst. This is a cyst which is more complicated, which is named, this could be a surgical lesion, and last but not least, grade 4, a renal cell carcinoma. This is the same example. I believe Professor Correas will outline this problem more in detail. I'd like to show you this experience from Charité. You see here there is no contrast enhancement in the central portion of that lesion. The meaning is this is a benign lesion and we can follow up this patient, no problem, no surgical evaluation is necessary. This is a kidney graft recipient And of course, you see here we can use our linear equipment to see there's no contrast enhancement in this hemorrhagic cyst, so no problem for this patient. And of course, this is very important information. This is the other way around. This patient came from the CT department, and there were a higher Hounsfield unit in this cystic lesion in comparison to this big mass, and this corresponds very well with the B-mode scan. And if you compare this directly with contrast-enhanced ultrasound, you see very careful there's no contrast uptake in the cystic lesion, so no problem for this patient, and of course beautiful reconstruction based on inversion fly-through mode. What about renal cell carcinoma? This is only an example where you see this matched very good between CT on your left and real-time ultrasound contrast base on your right. This is the venous system here of the kidney. There's also no thrombus from the tumor. This is of course also an important information, and this is a clear cancer in this example. The main focus on this is on shrunken kidneys. You see this is an MRI scan. Here's a focal mass, 1 centimeter. The kidney is 4 centimeter, often a problem in kidney graft recipients. And now we will know, is this a problem here in this area? And if you look very carefully, you see a perfusion only in this area. And this was a very small renal cell carcinoma in a shrunken kidney. Of course, also an additional and very, very important information for this patient. What about puncturing with such a system? Of course, you can plan a puncture procedure based on ultrasound, that's clear, but sometimes we have very obvious patients or it's a difficult localization, and for the future it's much, much easier to use image fusion technology. Of course, this is a technique without any radiation exposure, also for the clinicians. And you see how it works. This is our target, this is our guideline, the needle is coming, we pushing the kidney, then you can push the fire button and we have a success to the kidney, 2 centimeters, a very safe and easy procedure to analyze this area here in this situation. Focal liver lesions. And first we have to talk on the monitoring of the therapy, and I'd like to show you this example. This was a lady with breast cancer under chemotherapy. And this was the first and initial MRI scan where we see some metastasis. This is the corresponding ultrasound image 2 months later under chemotherapy. And this is the same lesion under contrast application. This is the live image. On your left, MRI, on your right, real-time ultrasound. And you see there's a progressive disease in size, and we see some additional lesion which were not visible in the MRI scan before. So the meaning is horrible situation for the lady. There's a progressive disease under chemotherapy, and of course this is a big problem, but you can talk with your clinical colleagues, and it's very clear to compare a target lesion, additional lesions, to measure these lesions based on this technology. This is a very special setting where we used so-called hyperthermia monitoring, and this is a method to perfuse melanoma metastasis with heated blood. And in this example, the hepatic artery is claimed to keep the metastasis anoxic under the procedure. We used 40 degrees of Celsius over 60 minutes for this therapy. And of course, this is the final end of a therapy strategy in such a patient situation. And you see, this is an example of the therapy before. This is a B-mode scan of a metastasis. Of course, it's clear to measure this, but it's much, much easier to compare directly the CT scan 2 months before with the actual ultrasound scan. You see here the same situation. I'd like to show you this once again with a mode which is named acoustic structure quantification, which describes you the heterogeneity of a mass, and especially if you have central necrosis, this helps you very nice for your daily routine. And this is the setting of our first 5 patients, and you see this was a good responder, this was a mixed responder, and this was a low responder. And I will outline the mixed responder and the low responder. And this is the range of the LDH. And if we have a very high LDH, there was a good success of the therapy. And this is the example here in that lady, the PET scan after the therapy, no metastasis in the liver. Of course, some metastasis in the bone, that's clear. That's a horrible situation here for the lady. But you see, that's the CT scan after the therapy. This is a big necrosis, and that's the ultrasound scan 2 months later, where we see the necrosis or seroma, it's definitely smaller than the therapeutic situation before. This is a 4D contrast-based image where we see after 18 seconds the big necrosis here in the liver segment 6 in that case. And of course, this is a good overview, a good success of the therapy. This is a case of a complete responder. This is the example of the mixed response. We see the PET scan before with a high uptake in the metastasis, once again, melanoma metastasis. This is immediately after therapy, which corresponds very well with the ultrasound perfusion. We see some cystic masses after 25 seconds, no bubbles inside, good success. Here in this metastasis, still alive, some bubbles. The meaning is this is a mixed response. 1 year later, a progressive disease, and I'd like to show you the actual ultrasound scan. From this patient point of view, we see a high and early contrast enhancement in this small focal lesion. And if we skip the scan plane, we see some necrotic areas here. So the meaning is we have follow-up for 1 year in this patient, and this is a success of the therapy, but this was a mixed response. This is a low responder. Please look very careful on this. This is a young man where we see hyperechoic melanoma metastasis. This is a rare case, and we see a progressive disease after 3 months. This is immediately before the therapy starts, and this is the situation after therapy. This big metastasis, the target lesion, there is a final end, a death of this lesion, no contrast uptake. But if you look careful on this situation, here's an additional metastasis with a highly enhancement. This is this purple curve here. This is the result from the CT after therapy, and this is the progressive disease 2 months later. So you see there is not a big success, low LDH in that example, and I'd like to show you the early enhancement. Here we are, we move on, so not a big problem. You see this is the mess from the initial CT, and you see here this is a recurrence, so of course a horrible situation in this young man, 30 years old, and a horrible situation here, no success of the therapy, but it's very well from the monitoring point of view to use contrast-enhanced ultrasound. Last point, staging CT. What is the problem if we deal with staging CT? The problem is that we mostly use an uniphasic technique with a bolus administration after 60 seconds. The reason is we will scan hypervascular metastasis very easily in this setting. Sometimes we have hypervascular focal liver lesions, for instance, renal carcinoid melanoma metastasis, as well as FNH or high-flow hemangiomas. And in the portal venous phase, most metastases are hypervascular, but we have a lower sensitivity in lesions smaller than 1 centimeter, and the differential diagnosis could be an hemangioma or a simple cyst. And we know so far the overall sensitivity and specificity of contrast-enhanced ultrasound for this topic is in a range of 93%, and this is the actual publication this year where we have this very nice result from the contrast point of view. And a few examples, hypervascular mass first, staging CT in a melanoma patient, question what happens. You see this is an isoechoic lesion. We have a central artery here based from the power Doppler signal. We see an early enhancement, isoechoic in the portal venous phase and in the late phase, benign lesion, typically for an FNH. Another example looks quite similar. Once again, hypervascularized mass, isoechoic from the B-mode scan, peripheral globular enhancement, very fast. This is an example of a high-flow hemangioma with very high contrast. And you see once again in the late phase isoechoic, so the meaning is definitely not malignant, no problem here for this patient. And this shows you how we can use this technology. So this is an example for a staging CT in a lymphoma patient. This is the lymphoma in a para-aortic localization. And you see there was an incidental finding of a small liver lesion, which corresponds with an hyperechoic mass, looks like a hemangioma. And you see the contrast inflow, peripheral globular, a fill-in over the time, isoechoic in the late phase. No problem here in that example. And I'd like to show you the real-time situation here from the lymphoma, hypoechoic, very well vascularized. And we can use, once again, the acoustic structure quantification procedure, where we see it's very homogeneous, which is typically for the lymphoma situation. And the last question, the vascularity of the mass. You see this is the second bolus administration. First, for the hemangioma, we see contrast in the aorta. It takes a few seconds. Then we have contrast, very well vascularized mass here. Then contrast in the vena cava. We can destroy the bubbles once again to see what happens, to check the situation. And you see this very strong enhancement in this lymphoma patient. A short outlook, a very rare case here of an angiomyxoma of the uterus. And this was a 34-year-old female with 3 times in vitro fertilization before, with a spontaneous abortion. And the question is a follow-up of these rare tumor. And this is the follow-up based on MRI. And for the future, hopefully we can follow up this also from the ultrasound point of view. It looks slightly hyperechoic in the same scan plane in correlation to the MRI scan. It's more a stiff tumor area. It's very well vascularized based on a power Doppler evaluation. We see some cystic nodules in the tumor. We have a very high contrast resolution based on a contrast information. And I'd like to show you, of course, once again, the real-time procedure where we see the contrast inflow over the time in correlation to the MRI scan, perfusion of this mass. And we see also very high perfusion in the cervical channel and, of course, these small cystic lesions. This is also an interesting case of a pregnant woman. We see this should be a small boy. This is the surface of the small boy. Baby facing is also possible with these technologies for a radiologist. And this lady came from the MRI department with the question, are there any septic areas in that big mass? And if you look at this, we have a very high resolution on ultrasound to scan these septic areas. And this is an example to use more and straightforward technologies. This is a fly-through technology, a case-based study. Look at this. This is not a bifurcation. That's the carotid artery. That's a trifurcation. And now we are Captain Kirk and feeling free and fly through these normal vessels. Trifurcation, very nice images in the so-called fly-through way. I believe that's a technique for the future, to have 3D for fusion technology, an example of a plaque. And once again, fly through, feel free, and we see the 50% up to 60% stenosis in that case based on the inversion fly-through case. I have to say thank you so much for your kind attention.